My name's Wroblewski, for those of you who don't know me. I know a lot of you. Okay, so here's the territory we're going to cover with this patient engagement and three dimensions of it, which would be the compliance, the engagement, empowerment. Why is it a hot topic? How is it showing up in stage 3? How do you get started with it? Case study, a few other little stories, and then the role we play in facilitating your success with patient engagement. Now this statement I find, let's see, it's not what you would expect, because patient engagement for most people has been looked upon as something the practice provides, that you go out and you drag people kicking and screaming to take more responsibility or participate. And this statement is actually turning that on its head. It's really saying the initiative or the motivation starts on the other side. It's the individual doing something to obtain the greatest benefit from the healthcare services available. And this is what I mean about the paradigm shift. And it's, from my point of view, it's a fascinating assumption. Is this really true that if all of us as patients actually take more responsibility, will outcomes improve? Will things be better? And in some ways, even in terms of the global policy, will costs be contained? So I'd like to chat about that as we move on in terms of your sense. Do you agree with that? Do you agree that if patients, or actually all of us, took more responsibility, things would be better? So we'll get into that more. The culture shift is huge because it really is talking about sort of moving away from that central command. What is it? The great leader approach to life, where you have the primary care physician running the show, and then everybody else sort of scrambling around serving the primary care physician. And as we all know, it's much more of a team effort. And the reality of that is now coming into alignment with the methods of practice. So here's where this goes: patient-centered care, cultural shift, clinical team, family, patient. And particularly with pediatrics, family is a big deal. It's interesting at both ends of the spectrum, and then when you get older in the geriatric territory, also family. So it becomes somewhat of a mirror in terms of a clinical team, and then the family as well. So I have a little story. My colleague Liz Wroblewski, who you've probably seen, she's doing all kinds of presentations. So this is a true story from her, and she has my permission to tell it. So she tells a story. One day she wasn't working, she was at home doing laundry and listening to some of the talk shows, and she gets a call from the preschool where her son was attending, and they said, something's happened with Toby, he's had an accident, meet us at the hospital. Okay, so a mom doesn't like to hear that. You know, that's not the news you want. So she gets to the hospital, and Toby's in the emergency room, and she's thinking, oh, you know, what could possibly have happened? What's the deal here? And then she hears his cry. And so she remembers from her dad, who was a firefighter and EMT guy, and he said, in any situation, that's what you want. You want to hear that child cry. That's a good sign. So she was relieved. So then she eventually got to see him and talk to the preschool director, and she said what happened is he was on the playground and he just collapsed. He just collapsed and turned blue, and we were about to start administering CPR because he wasn't breathing, and then he started breathing, and we thought he had a seizure. So they got to the emergency room, and so they didn't know exactly what was going on. And there he is, because they're obviously running a lot of tests in the brain and neurological EEGs, I guess they're called. So then they went to the pediatrician the next day and said what's going on, and then referred from there to MGH, the neurology people. And so Liz says you wouldn't believe the amount of tests he had. Blood tests, these EEGs, all kinds of things, over and over, trying to figure out what's going on, what's happening. And so eventually she gave me some of the lingo, which is out of my element here. Tonic-clonic refractory seizures. So it's like if you've ever run into that with anybody in your family, like my stepdaughter was diagnosed with cancer years ago, and then you learn, oh, non-Hodgkin's lymphoblastic lymphoma. So these words just come into your life. You've never heard of them, you don't even know what they mean. So with Liz, there are all these new terminologies and everything, and what's going on. So the tests were done, I think 2 years ago. They did it overnight just before Thanksgiving. And she said what they diagnosed was myoclonic astatic epilepsy, MAE, also known as DOSA syndrome. So part of what they were testing for was this a one-time event, or was this some sort of a chronic condition? And it was looking like it was a chronic condition. So Liz was kind of devastated by this, but then she went on the internet, Googling everything, and trying to learn what's going on. What does this all mean? And she was saying, she doesn't know if that's always the best thing to do, but she wanted to learn what was going on. And so she eventually sort of got a handle on it and said, you know, just having some understanding felt better. I didn't feel helpless. I didn't know, you know, what would happen or where the solution was, but just having that little bit of comfort that I now had some perspective, you know, was really, really helpful. So from there, she then got involved with the patient portal. So then she was monitoring what's going on, MGH, with all these different docs, these different procedures. She could interact with the docs, and she was feeling very involved. And she was saying, you know, because of the complexity of the treatment, which was all kinds of supplements, drugs, and then he had a whole dietary regimen, it was all there. And Dan, her husband, when they would forget now, what was his dosage or what are we supposed to be doing, they could just go back into the portal and be refreshed in terms of what the requirements were and stay on track. So she felt very empowered, I'd say, because she was getting this information. She could always talk to the docs by phone, and of course they had their visits, but she felt really included in that entire process. So her idea with all of this, she said, the challenge of it was that they had a separate portal for the pediatrician and a separate portal for MGH, that she would have loved if it was one portal for Toby. So there he is, September, doing well with his big smile, and I've met him and he is as delightful as he looks. So the reason, Liz and I were talking about this slide presentation and we had all this, and then she said, well, what if you tell my story? And I said, well, let's see. And I began to look at this and I said, you know, everything you did fits into this thing of what is patient engagement. Understand health and health conditions, yes. Access to the health data, well in this case it was Toby's. Real time, near real time. Improve the communications, take more responsibility. And again, this had a whole kind of monitoring of his diet piece involved. Experience, improve the experience of interacting with the system, educate their families and caregivers. And this is another thing she pointed out, because she had access to all this information on the MGH site that was useful, like when he went to school, to provide to the people at the school, so people would understand what he was facing from a health perspective. Getting support, obviously. So it was actually interesting, we both kind of chuckled at it, that because this slide, out of context, is just a bunch of ideas or thoughts, but if you put a real situation into it, you can see where it actually has significant meaning. So these are three dimensions of what we're talking about: compliance, engagement, empowerment. Engaging a patient does not equal compliance. What compliance means, and in some ways, I prefer the word adherence, which is from my background. When I ran the AIDS project in Rhode Island, in the early days, in the 80s, there was an actual position called adherence nurse. And the importance of that was, in the early days, particularly people who are HIV positive had to take 1 million different drugs, or cocktails as they were called. Very intricate, had to be precisely timed. It was a big deal. And so, because of the almost experimental nature of it, there was actually somebody on staff, a nurse, that would visit the HIV positive people and work with them on following this regimen. And that was called adherence. So from my point of view, the first step of engagement is actually going to the pharmacy and getting your prescription, and then actually taking them. So even as simple as that, patient engagement is an important piece. Another side is actually showing up for your appointments. So a lot of this, it sounds like, wow, this is so basic, but if you look at where a lot of Meaningful Use stuff started from, it was with the hospitals in trying to reduce readmissions or visits to the emergency room, or drug-to-drug interactions, all this sort of really basic stuff that was falling through the cracks. So even though it's not compliance or adherence, that's a real important building block, is the relationship between what is the treatment plan or the prescription and the patient's willingness or ability to adhere to that. In terms of what Liz and Toby are dealing with, he is apparently quite a trooper sticking to the diet, which I'm not sure what it all is, but it's low carb and gluten-free, not a lot of fun stuff with sugar and so forth, but he's apparently a real trooper and just stays to it and doesn't seem to feel overly oppressed by not having all the candy at Halloween. So here's a little story, which is another side of patient engagement.
The doctor will be with you in a moment. Difficult.
Elaine, you shouldn't be reading that. Now tell me about this rash of yours.
Well, you know, I noticed that someone wrote in my chart that I was difficult in January of '92, and I have to tell you, I remember that appointment exactly. You see, this nurse had asked me to put a gown on, but it was a mole on my shoulder, and actually I'd specifically worn a tank top so that I wouldn't have to put a gown on. You know, they're made of paper.
Well, that was a long time ago. How about if I just erase it? Now, about that rash.
But it was in pen. You fake erase.
All right, Miss Menace. This doesn't look too serious. You should be fine.
What are you writing? Doctor? You are not going to believe what happened to me at the doctor's office today.
Not the gown again.
No, I was looking at my chart and it said that I was difficult. Why would they write that?
They've gotten to know you.
And then the doctor writes more stuff down there and he doesn't even look at my rash.
Why don't you find a doctor that doesn't know you're difficult?
Elaine, you really didn't have to put on the gown.
Oh, it's my pleasure. I love these. You know, in fact, I've got one at home. It's perfect when you just want to throw something on. Hi.
Oh, thank you. Alrighty. Let me just review your history before we begin.
Oh, where did you get my chart?
From your last doctor. Standard procedure.
You know, I can tell you my whole history. Let's just...
Okay, let's take a look. Well, that doesn't look too serious. You'll be fine.
Oh, please, please, it's really, really itchy. Get in there, get the chart, and get out. You got it?
Yeah, no problem. Listen, let me borrow your scarf.
What?
Yeah, it's
This?
nice, yeah.
Here.
All right. So, one chart coming up.
Okay.
It's Bennett, right?
It's Bennis, you jackass. My last name is Bennis. Yeah.
So I like what you've done there.
May I help you?
Yes. I'm Dr. Van Nostrum from the clinic. I'm going to need Elaine Bennis's chart. She's a patient of mine, and I don't think she's going to make it. It's very bad, very messy.
I see. And what clinic is that again?
That's correct.
Excuse me?
From the Hoffer-Mandorf Clinic in Belgium.
Oh, really?
The Netherlands?
Where's my chart? Did you get it?
No,
What? What happened?
I don't know, but now they got a chart on me.
What do you think? Patient engagement? So that's like whenever that was back in the 90s, which is the old style. Whose chart is it kind of issue? And I think that's still evolving in terms of it's your chart, you know, as a patient, or my chart. And the whole idea of the patient portal is like a step, and not a very big step in that direction, where there's a sense of, and that's part of the engagement or participation, is the idea that this is your chart and you're knowledgeable about it, you know what's going on, and you have some ability to interpret it. So here are all the different elements that can come together to improve patient engagement and lead to patient empowerment. And I go back to Liz's story, and I think that they were moving down this road. But if you think of it, why is that possible? Because both Dan, her husband, and Liz were really ready to put in the time and energy. And that to me is, it's a big assumption around all of this, is are people willing to put in the time and energy? Because if not, all of this hocus pocus isn't going to go anyplace. But these are all the different little elements that are coming along. And I think do we have it on there? PHR, personal health record. So there are more devices coming into play, you know, portable devices where people can gather information on themselves, send it in, or you can get the information from the docs, whatever, on portable devices, and you're not locked into actually using a computer. Stage 3, meaningful use. So these are the three: the patient access, which we're already talking about, care coordination, patient engagement, health information exchange. And again, if you were at my session this morning, that term has been redefined to mean summary of care. I don't know why they did that, but so typically we view that more as the information highway, but it now also means summary of care. API, which is the ability of the EHR to communicate with a variety of devices. So that's trying to take advantage of the proliferation of different devices.
Well, that API could go back to what were the real key issue, like another issue brought up over there too, is bringing in the different records from different facilities. So, and you brought
Yes.
it up in Toby's story as well. The hospital has its records, the pediatric practice has this, the primary care, the specialist. They all have their own individual records, so you need to pull that together so you have a patient-centered record. That's really what helps the patient the best. And you need to even go further, so like the pediatric, from the pediatric side, I'm a parent, I have 3 kids, I have 3 different patient portals I have to go log into. That's a pain in the butt too.
Right.
So is that consolidation? So an API, some type of tool of bringing that information together, is really what would be more beneficial
Yep.
for everyone.
So it's a good illustration of its potential. Again, it's all just coming off the drawing board in terms of implementation. Michigan is in patient-centered care, we know that. This is something interesting, strategic approach versus tactical. Again, I think meaningful use drives us towards tactical, like these very specific things. And part of it is like what I was suggesting is, what is the strategy of the center? What is the strategy of the clinic in terms of engagement? Where are those little touch points where engagement can be supported? So here are the phases of patient engagement. Pretty much everything we've been talking about. The last one, e-community, which is where there are support groups. I know Liz is part of a support group network on Facebook for parents of kids with epilepsy. There's also input in terms of the practices, advisory groups that help inform the practice of what would increase patient engagement. So that's another way of looking at it. Case study. Okay, this is somebody named Michael Zarukian. He's involved with HIMSS. He's a doc in Michigan. So he tells a story. He was seeing a patient. The patient was real frustrated, having a struggle losing weight. So he noticed they both had iPhones, and he said, let's see if we can find an app that deals with weight loss. So they found this called Lose It. Anybody ever see this? Okay, so what it is, it's an app, not just iPhones, but all the others as well. And then you can put down what is your goal, how much weight do you want to lose, even per week. And then it can track calories. It gives you sort of a diet in terms of, okay, here's how many calories you have per day, exercise, all of that. So then he took it the next step, and you can sort of create a community. So the doc said, okay, I'm going to do this, and I'll share my information with you if you'll share yours with me. So they did, and then they eventually got more patients doing it. Now there's no PHI involved, and this isn't part of EHR technically, but he was seeing it as a way to get the engagement process going, and he found it to be successful, and he said it did not take additional time. So I think that's always what I'm hearing today is time is precious, and so there are all these extra things that can be done, but where is the time to do them? And then also in terms of billing, are these activities billable? I know a group that I've worked with, the Pediatric Physicians Organization at Children's, launched an obesity program for their, because they have, I don't know, 80 different practices, and they found some of the most effective interventions were not billable, which was very frustrating because they were finding something that worked, which were like teen groups or support groups or things like that. And I think that's also part of patient engagement that could be sort of an unintended consequence that patients are actually coming up with. You know, what would really be helpful is, and then it falls outside the scope of what's billable. Even like this gadget, you know, if you look at, okay, what would it take to actually provide some financial reward for doing it? MeHI, that's us. This is something, the readiness tool is for, I would say, larger organizations, but smaller ones can use it as well, which is you begin to do almost an assessment of engagement throughout the practice. And how are you doing? Are you missing opportunities to increase engagement? Are there things you could be doing that would be, you know, easy to do, but you're not doing? Questions? And that's me. Okay. There were some more comments, weren't there? Yes. Yeah.